Okay, here we are. It's Thursday, April 4th, and I'm here. I'm Chris McMahon. I'm here with Carrie Burmeister, my co-host, and today we have Tim Swayer with us, PA, who works in emergency
Yep,
medicine.
he's an emergency physician. Yep.
He's an emergency physician, and we're going to talk about some do's and don'ts of emergency medicine and what's appropriate for emergency medicine and what isn't. So I'll just get started. And Tim, I'll ask you, why did you choose emergency medicine? And is there additional training required for that?
So as I was going through med school, I kind of did our rotations that we go through and all the different fields and kind of liked a little bit of everything and did my ER rotation and liked the flow of it and kind of the fast-paced atmosphere and still getting the variety of all the different fields of medicine and just kind of that general scope of medicine. So just kind of fell in love with the field. So
It's different every day. That's a nice thing.
it is, yeah. Yeah, it's not just going to an office and seeing the same thing every day. There's always something new coming in, some excitement, you never know what you're gonna get. So it's kind of nice having that variety.
What kind of schooling did it take, Tim, beyond just med school?
Yeah, so it's 4 years undergrad, 4 years med school, and then the residency is 3 to 4 years, based depending on which program you go to. And then from there, some people go into different fellowships in ultrasound or critical care or EMS or administrative fellowships, but at least 3 years of post med school training.
What are common emergencies that require an ER visit? And how do people determine if they need to go to the emergency room? And I'll just caveat by saying this for any of our our viewers, our wide audience, that this is just generalizations. If you think you have an emergency, go to the emergency room. So
Yeah, most definitely. It can vary greatly, from somebody having chest pain to abdominal pain to vomiting, diarrhea, dehydration, pregnancy related complaints, any like trauma related injuries, broken bones and lacerations or car accidents, respiratory complaints like difficulty breathing, pneumonia, COVID, flu, all the respiratory stuff can require an ER visit for further testing and everything.
Well, just out of curiosity, if you're having chest pain, how do you discern it? Is this really a heart issue? Is this a GI issue? Is this anxiety? How does the average person know that it's really truly chest pain and they need to go to the emergency room?
It can be very difficult, and no one presents the same way, especially elderly or female patients can present differently. They don't typically have the crushing chest pain. They can have jaw pain or arm pain, or it can vary greatly, for symptoms related to a heart attack. So it's hard for layperson to know exactly when they need to seek care and go to the emergency department. I often tell the patients that say, "Oh, well, I came in for nothing. It's not a heart attack. Why did I come in?" It better safe than sorry. Come in, get evaluated. You don't know if it's a heart attack until you come in and get some testing, such as like an EKG, cardiac markers. You get other blood tests and X-rays and things to rule out, any bad conditions such as heart attack.
like when you see signs of stroke, how important is it for a patient to get to the ER quickly once they recognize symptoms, or once a family member recognizes symptoms in someone that are stroke related or seem to be stroke related?
Yeah, so definitely recommend within 3 hours to get evaluated. The reason for that is they can get TPA or different clot busting medicines that can only be given up to 3 to 4.5 hours. So the soon as patients recognize potential stroke symptoms, they need to come in to get evaluated as soon as possible. Even up to 12 to 24 hours, there's certain neurological like interventions that the specialized team can do to go in and retrieve the clot and restore blood flow to the parts of the brain that are affected. A lot of times we'll see the patient, had some symptoms and they decided to go to sleep and just see if it gets better in the morning, which is definitely what we don't recommend. We want them to come in and get evaluated as soon as possible so they can have as many options as possible to treat their symptoms.
What would be some of the symptoms that a person would see, or a family member would see in someone?
So one of the mnemonics that we tried to relate to the patients is be fast. So B is for balance. So any balance issues, dizziness, trouble walking. E is any eye symptoms, any blurry vision, double vision, loss of vision can be related to a stroke. Face is F, so drooping of the face. A is any arm, weakness, kind of goes along with leg as well. If you see like a drift or difficulty coordination with your arm or any weakness to one side. S is speech, slurred speech, difficulty getting the words out that you're trying to say. And then T is for time. So as soon as possible to call EMS and get in for evaluation.
Should you go by the squad?
That's the best bet, is calling the ambulance and getting in as fast as possible. And they can evaluate other reasons, maybe for the symptoms. Sometimes like a low blood sugar can cause stroke-like symptoms, so that the EMS can start evaluating and seeing what is wrong. And it's the safest thing for the patient, especially if they're weak on one side. They try to come in by car and they end up falling and injuring themselves or whatever else. So would definitely recommend, if in the acute stroke-like symptoms, to call EMS and as soon as possible.
This might be a stupid question, but does age factor into this? Like, so the older you are, do you need to be more aware of these symptoms? Because I mean, I know young people have strokes on occasion, but it seems to be it's more older population that is affected with strokes.
It is, yeah. As the risk factors are developed over time, as we age. I mean, they're at much higher risk of developing a stroke and having detrimental sequelae from the stroke. So, um,
Diverting topic here. We all know about the increase in fentanyl use and opioid use. Do you guys see a lot of drug seekers in the emergency room?
I mean, we do see quite a few people that come in with pain-related complaints. I mean, we give it the benefit of the doubt and evaluate their pain. Some things that can raise some red flags for us if they come in very frequently with pain complaints. Kind of raises a red flag for us to kind of make sure that they're not abusing medications. Also, we can run an ORS report, so it's a national database that shows prescription narcotics, that we can evaluate, how often they're getting scripts and if they, potentially are abusing pain medicines. We definitely want to be a good steward of pain medication. That's really been cracked down by the federal government to, limit the amount of medications that are being given out in the length of the prescriptions, just because of the pain crisis that's, kind of struck our nation. For these patients, try to get them resources, try to get them, if they are interested, get them to rehab programs or, pain management or other drug rehab programs. Also, we can offer like Narcan take-home kits, which can be beneficial if they would take too much of their pain medicine, or, patients that do come in for, an overdose of fentanyl or heroin or something like that. We often try to give them a take-home kit and, counsel them to obviously stop using drugs. But if, they're in that scenario again, at least they have that resource to hopefully prevent a fatal outcome.
I read the death results in the paper every week, and I swear at least half are still overdoses. I mean, I don't know if it's gotten better with Narcan being available, but it seems like there's still a lot of people dying of overdoses of drugs.
And the problem is fentanyl can get laced into the, other drugs that they're using, and it's a minuscule amount that can cause a fatal overdose. I mean, the amount of fentanyl that could produce this is, I mean, less than a teaspoon. I mean, it's a tiny amount. I mean, just a fraction of a teaspoon that could cause a fatal overdose, and it could be laced into marijuana or whatever other drug that they could be using. So that's a lot of times where they'll get a fatal overdose is, when they're not expecting, a stronger medicine like that.
How do you handle those patients that come in that are strictly that you can tell, or you frequent flyers? They're routine patients that come in that are basically drug seekers. Is there a professional way you handle those, or how you deal with them, or you just treat and release like normal?
Yeah, I mean, I try to be respectful to them, and try to we want to treat them with dignity, and not accuse them of necessarily being a frequent flyer or abusing. But often if we do see a big red flag that they could be abusing medications, we often will try to just give them resources, and yeah, obviously refrain from prescribing anything further, but get them offer them resources and offer them a referral to maybe pain management where they can get some relief of their pain. But just let them know that we can't allow them to use the ER for these chronic pain related complaints, and their prescriber for pain medicine, that needs to be from one prescriber. That way they can monitor their relief of the pain from their condition, and monitor for any side effects from the medication. So really try to get it back to one prescriber that could help them out and give them best care moving forward.
I would think those conversations could be uncomfortable sometimes.
Very much so. And they can get heated. The patient can get mad and angry, and they can lash out and be upset that they're not getting what they want. But if it's not safe and it's not the right thing for the patient, we just have to kind of hold our ground and make sure that we're doing the right thing. So
that leads me to think, have you had to increase security in the ERs, let's say over the past 5 to 10 years, with some of the stuff that's happening in our world today, and especially with like the increase in the opioid use and things like that?
We have, and often we'll have security on site, and depending on the department, we'll have metal detectors and police on site at the hospital. So just to keep everyone safe and screen the patients and make sure that we're not putting our staff at risk.
Important.
How do you determine if the patient needs to be admitted to the hospital, or just like, we call them a 23-hour admit?
Yeah. So often it'll be dependent on what they're coming in for, what their diagnosis is, how their test results are. If we feel like they can be discharged safely within 48 hours, they could be admitted into a 48-hour like observation versus a full admission. We also have a like utilization review that we can have them review the chart, and they have all the criteria that what meets inpatient criteria. So they'll go over the chart and look and say, XYZ is met. They can go to, a full admission versus an observation, which is important when it comes to, billing and insurances and Medicaid, Medicare, and everything. So we want to make sure we're getting them in the right designation. So, they're being billed appropriately and not getting overcharged, or, that their insurance is going to cover their care. So.
Yeah, that's a big deal. I'm trying to make the patients even understand the difference, because they're thinking they spent the night. I'm an inpatient, but they don't fully understand the observation piece of it when it comes to insurances. And insurances like to play these games. Unfortunately, usually hurts the patient's pocketbook.
And unfortunately, we've had some difficult conversations, with patients when they don't meet inpatient criteria. They just meet observation, and sometimes they don't want to stay in the hospital if they only meet observation. So it can be a hard conversation to have with them.
past 10 to 15 years in emergency medicine, has it evolved with the birth of the urgent care facilities? And like, what type of patients do you see less of now with urgent cares open?
Urgent care will try to filter off a lot of the very minor things, the earaches, the sore throats, the cough, cold symptoms, and kind of minor symptoms like that. So maybe a little less of that in the main ED when they're open, because urgent cares are typically only open 9 to 9 or 8 to 8, depending. So at night and early morning, or when they're closed on the weekends or whatever, we'll get more of that in the main ED. But some of those very minor complaints still maybe see a little bit less of during the main hours when urgent cares are open.
Well, when Carrie and I were young, emergency room was the only option.
Mm-hmm.
So that we didn't have urgent care. So whether you just needed a couple stitches in your hand or whatever, you were going to the emergency room. And ultimately, I think we've learned that that's just really poor utilization of emergency services.
Mm-hmm. Yeah, and patients will have a much lower copay, with urgent care visits, and if they can stay out of the ER and keep those open for more serious emergencies, it helps everyone out. So it makes sense.
Yeah, we just have to work to educate the patients.
Yeah, and sometimes it's hard, because they don't always know what their the best route to go to, ER versus urgent care. And sometimes the urgent care, they'll go in for chest pain and they're like, no, you got to go to the ER. Or so it's hard for patients, because sometimes they'll have just kind of vague symptoms, and it turns out to be a heart attack. So it's just hard to sometimes know exactly where they should go.
What about, I know we didn't kind of pre-screen this one, but what about the freestanding, Tim? What are I think I know the strategic reason for having a freestanding ER, but is there any issues with freestanding ERs and trying to transfer patients when it is a more serious type of condition that the patient has, like a stroke or a heart attack or something that is more serious, trying to get those folks seen and treated and to the proper facility when they need additional care? I don't know.
So yeah, I mean, sometimes there can be delays with transport, which can make it tough. It, obviously it's a full ER at the freestanding ER, so they have all the services available to take care of an emergent condition. But getting them to the specialist that they need is can be delayed. Just waiting for the transport, getting them there in appropriate time. So sometimes if they're closer to a main hospital, sometimes it's better to go there if they're having a serious emergency that way. Or if it's something that requires specialists, it may be best to go directly to the main campus where they have all the specialists available and everybody they need. But often if it's an emergent condition, like a bad heart attack, stroke, something very critical, they can get bumped up on the uh, list for transport, or even a flight out of the facility to get to the main campus. So there's kind of a triage process to who gets the ambulance first. So if it's something serious, often they can get there sooner than needed. So.
And you did say that your full ER, these freestandings are full ER, so they are capable of stabilizing and keeping monitoring on these patients until they kind of get transported, right?
Correct. Yeah. Yeah. I mean, they have all the X-rays, CAT scans, everything. If the patient would need to be intubated, or different drips and different medications, they have that available to kind of stabilize the patient and get them to the main facility.
So in today's world, we all know that your perception's your reality. And I might think my headache is an emergency, and Carrie would take a couple aspirin and go to bed. Do people ever get told that they don't need the emergency service when they show up, or told to go to urgent care, or you just see everyone who presents?
Yeah, I mean that's the one good thing about the ER is we're going to see everybody. We have the duty and we have the responsibility that we have to see everybody that comes in, no matter how minor the symptoms are, because you don't know if you don't know what you don't know. So if you come in with a minor headache, it could be something serious. So in the ER we're going to see everything. It's not like we're going to say, oh, you can't be seen in the ER, you need to go to urgent care. So and the urgent care can flip that. The urgent care, if you go to the urgent care, they may say, hey, you need to go to the ER because this is more critical than we can see. But in the ER, we're going to see everybody that comes in. We have that duty to perform a medical screening exam and do what's appropriate for the patient. So,
Is there a hierarchy to which emergency patients get taken care of first? You kind of alluded to this a little bit.
yeah. So when they come in, they get triaged. Typically, it's a nurse that'll first take them back and get them triaged, and depending on the chief complaint, how old they are, their vital signs, and what the patient describes to the nurses, they'll kind of triage what level of ER patient they are, and try to triage them appropriately. Where acute emergent condition is going to come back right away. Something that's kind of minor and could wait a while is going to be kind of farther down on the triage list in the waiting room. So, like a heart attack, stroke, they're going to be a higher triage level. They're going to come right back versus the sore throat, the earache. That's going to be kind of triage at a lower level and is more appropriate for waiting if there's a need for
So I'm going to assume that, like, if you get transported by the squad, you're going right back.
yeah. Typically, they're going to be directly into a bed and not have to wait. That being said, if the department's completely full and you call the ambulance because you stubbed your toe, you may get triaged lower and you may have to wait if there's more critical patients. But typically, the patients are calling the ambulance because they're critical and they're going to come right back and get seen. So,
How is an ER staffed? For instance, compared to like how many beds you have in the ER, let's say you have 10 beds, like how many physicians is that? How many per shift or something like that? Just so people are aware, I think we go to the ER and we expect to see somebody, and you typically see a nurse right away. Like you said, you get triaged and then, they come in and so on. But for physician staffing, is there a patient or a bed ratio that you guys staff to that's kind of nationally accepted or typically accepted, or is it based on volume, or how does that work?
yeah, it's often based on volume, just about how many patients are coming on and what time they're coming in. If they're all coming on during certain times, then they may have double staffs, two physicians or a physician and a PA, or so often it's based on the amount of volume and how many patients are being seen per hour during that time. Same with nursing; they're going to be staffed a certain ratio depending on how many patients are coming in, and typically they'll have a certain number that are there 24/7 no matter what, and then they staff up during the day when it's busier. So, but all ERs are going to have at least one physician on 24/7, and then depending on patient volume and how many the time frame of when the patients come in, they'll have either a second doc come in or a PA or nurse practitioner that helps run the department and see all the patients in a timely manner.
And that's something you guys track too. You track your peak hours and things like that because it does kind of trend when patients seem to get injured more or
Right.
sick
Yeah,
more, I guess. Correct.
Yeah, it's often kind of ebbing and flowing, and you're kind of modifying your staffing model based on how the volume's trending, and shifting the shifts to better capture the best time to have the provider there for the patients. So it's always kind of a moving a moving process to make sure you're getting the right number of providers there to take care of the patients.
What about the hospital staff? Do you know, do they like, I'll just say on a OB-GYN floor, if they have low census, they're sending people home.
Mhm.
So in the emergency room, do they ever send staff home or move them to another department or?
Yeah, sometimes they will if it's just the volume is the census is way down and there's not an expected flow of patients coming in. If it's getting later in the night or in the middle of the night or something, they'll start sending patients home if the department's caught up and everyone's seen and the volume's down. So sometimes that'll happen. And then on the flip side of that, sometimes we'll have providers that are on call, and if the volume is just taken off, we'll call them in and get them in to have better staffing. So
Do you guys have a backup on call? Or no?
yeah, yeah,
You? Yeah.
yeah. Um,
Well, that's
but
probably a good idea.
but fortunately, don't have to use it a lot. Usually able to get on top of things and make sure that we're seeing everybody and getting everybody moved through appropriately. So
And on the unfortunate side, it does impact your life when you are on call.
right.
Mhm.
The good thing about ERs though is we're not carrying a pager and we're not on call most of the time.
Right.
What about, is there any truth to the full moon effect? Do you really see more people like during a full moon? And what's going to happen with this eclipse thing?
Oh, I don't know. It sure seems like there's more craziness that happens when there's a full moon or stuff going on. I mean, we are expecting maybe potentially more patients during the eclipse, time, or at least the days are surrounding that, just because people are traveling in to be in the path of the eclipse. So there's been talk of increasing staffing and things over this, especially on next Monday, just to cover for the potentially increased volume of patients coming in, just because of higher people in the area. But hopefully I don't see a ton more.
Well,
I
and
work
schools
Monday.
are
I work
closed.
Monday afternoon, so hopefully it's not crazy.
They've closed schools. There's people a lot of people are traveling here. So, I mean, there's the potential is there.
Yeah,
Yeah,
and hopefully everyone wears their appropriate eclipse
that's what
glasses.
I was thinking. You're going to
Don't
have a
have
lot
a
of people saying they're
higher
blind.
injuries. Yeah.
Yeah, you
A
have
lot
to
of
have your special glasses.
Hmm. And there's a lot out there. I mean, some of the facilities we work at, they are passing those out. So, would want everyone to reach out and try to get the glasses and make sure you're safe and protecting your eyes during the eclipse. So,
Well, the last one in 2017, I worked at a hospital and they passed out the glasses to everyone. We were all standing out there with those glasses on looking, but it wasn't in the same totality as they said this one is. It was just small. It didn't totally cover the sun. But I think that it's probably just going to be cloudy and none of us are going to see anything anyway.
Always the
Probably-
optimist, Chris.
Well,
probably
look at our weather.
Northwest Ohio will be cloudy and overcast, and
Our weather, it's mostly cloudy. If you think about it, and it's cloudy a lot.
Yeah. Well, hopefully it cooperates.
Yeah, we'll see. Some people are scrambling to change their plans and try and go somewhere else where they think that it's going to be a better view, but good luck. Fingers crossed. So with the advent of urgent care, I think it's really changed the dynamic. I don't know if the rest of the population has caught up with the fact that, it's more cost effective to go to an urgent care versus to go to an emergency room. And I know they haven't because when I used to manage offices, girls say, "Oh, I had a headache. I went to the urgent care." I'm like, "Take 2 aspirin and go to bed." You're 24. There's nothing. But I just back when urgent care first came on, they didn't require them to be able to stitch. So if you needed stitches, going to the urgent care really wasn't helpful because it wasn't a requirement for, like, let's say the nurse practitioner, or whoever was there, to be able to stitch. Now they do require them to be able to stitch. So hopefully, but I'm not sure that everyone's aware of that. We used to try to educate patients, but
And it depends on the complexity of the laceration too. Sometimes they won't repair it at urgent care just because they don't feel comfortable with the complexity of it. I mean, one good thing about one of the departments I work at is it's an ER and urgent care at the freestanding ER. So it kind of takes some of that guesswork out. I mean, if it's an urgent care, they just get billed and there's an urgent care and they're seen and getting taken care of as just an urgent care patient. But if it's deemed that they're a little more critical and they need some more testing, they get upgraded to an ER patient and they
ER
get their
patient.
testing. So it's kind of a great win for, the patients, that they can get the appropriate billing, they have the appropriate care, and kind of takes that guesswork out of, hey, do I need to go to the urgent care or ER? So
Yeah, that's helpful.
kind of nice.
That is helpful. Yep. And it actually seems like you're looking out for the patient too, and the best means for their care. Yep.
Yeah, most definitely.
If what are a couple things that you wish patients knew that was just common knowledge among patients that it seems a lot of people don't know?
I know we touched on it earlier, but just the time sensitivity of a stroke. It breaks my heart some of the times that patients have a stroke that we could have helped, and they said, "Well, I thought it would get better. I just went to bed," and then they're out of the time window to get care and get treated. So that's hard. Some other things. I mean, I tell my patients often, they come in and they feel silly because they came in and nothing was wrong. I tell them, better safe than sorry. You don't know if you're having an acute issue, but if you were and you didn't come in, it potentially could be fatal depending on what's going on. So, I always tell the patients, better safe than sorry. Come in, get evaluated, make sure that you're not having anything major going on. And at least and we can rule out some bad things and make sure it's nothing serious. So
Yeah, it could be the first step to starting when they think that maybe it isn't serious, and then it could lead to you referring them to specialists or whatever for whatever symptoms they're having, which could be so much helpful down the road. Maybe it wasn't super emergent, but could definitely be the beginning signs of something more serious down the road. So
Don't you think it would be helpful if we could convince everyone to have a family medicine doctor? Because that could be a place to start.
Mhm.
They're always on call. So even if it is after business hours, you can get the doctor on call and you can at least talk to a professional and say, this is going on, this is going on, this is going on. And they can say, oh, you better get the emergency room, and or you know what, we'll see you first thing tomorrow.
Yeah. Yeah, that's a huge first step, is just having a primary care provider that they can see, and at least start there. And a lot of times the primary care providers can't see them. They don't know how serious it is or how their vitals are, or what, they don't have testing emergently available, so they'll refer to the ER, which is appropriate, so they can get the workup and get the care they needed. But that follow-up piece is huge, so they can follow up. And we may not find an emergent condition right now, but to follow up and to get that the outpatient stress test or that ultrasound, or get started on the blood pressure medicine, for long-term treatment, just all that good care that they need just on a long-term basis to make sure their cholesterol is good. And just the annual physicals are important, and their OB care, and getting their pap smears, and getting their mammograms, and all that kind of stuff that just is important to so it doesn't get to something more serious, more critical. They can catch something early if there's something going on.
Yeah, just good preventive health care, and
Right.
more or less taking care of yourself. I think that's the problem. And many times you see people that are frequent flyers to the emergency room, they do not have a family medicine provider, and
Mhm.
they're utilizing the emergency room as their primary care. And, they do the best they can, but that's really not good medicine. They're not going to follow up with you. They're not going to call you and say, you haven't gotten this blood work done. What are you waiting for? They're not going to do those things that your family medicine doctor would do.
Right. And they're seeing a new person, usually every time they
You're
come in,
right.
different provider, and there's no continuity of care, to say, to guide them, to the best care that's needed for them. So there's just, just lacking, there, when they could be getting great, follow up and continuity with their primary care provider.
Right. With someone who they have a relationship with.
Yeah.
Versus just seeing whoever when they show up at the ER. And where if they did have a family medicine provider, they would have someone that they have a relationship with who knows them. And it's so helpful.
Yep. Most definitely.
I have one more question. So if I come to the freestanding ED and you say, okay, we need to transport you because you need further care. Most of the time, the freestanding ED is affiliated with some health system.
Right.
Does the patient have a choice to say, no, I don't want to go to that hospital. I'd rather go to this one because it's closer, even though it's not in the system that maybe the freestanding works with. Does the patient have a choice in any of that?
They do. Yeah. They can,
Okay.
Typically we'll recommend staying in the system. So all the,
Sure.
healthcare and the EMR and all their things transferable to the next facility. And we have that required kind of affiliation with the main campus. But yeah, they do have a say in where they go. And sometimes, even to stay within the healthcare system, they may choose hospital A instead of hospital B, but it's still in the same healthcare system. So there is some of that where they can choose where they would like to go. And, depending on, the specialist that is needed and things like that. But
I think that's important that patients do have to remember they have choices in their own healthcare as well. Not specifically just to that, but just in general. So, yeah.
Mm-hmm. Yep, most definitely.
Yeah, choice is good. I don't have any other questions, Carrie. Do you?
No, Tim, this was great. Dr. Sawyer, sorry. You've been fantastic through the whole thing, and we appreciate you being on. Is there anything else that you'd like to tell us? I mean, you kind of went through what you just recently said you wish patients knew, so I don't know if there's anything else you want to add.
No, I don't think so. Well, thanks for having me on, and hope I
Thank
was able to help someone out.
You never know. We appreciate it so much. Thanks so much. Have a great weekend.
All right, you too. Thank you.